We're going to have a change in schedule a little bit. We're going to go with Lisa Halverstadt next, who's going to be joining us from San Diego virtually. So I just need to get my slide here for her presentation here. Joe, you want to just, while I start the introduction here, it's going to just be my intro for Lisa. Really, really excited to have Lisa join us again virtually. Ms. Halverstadt is a senior investigative reporter for the Voice of San Diego. She has dedicated years of her professional life to covering San Diego region's homelessness crisis. She started her career at the Arizona Republic in Phoenix before moving to San Diego. I love this picture. I just love that picture. It's like investigative reporter to the max. I mean, those eyes, like, you better tell me the truth. I love that picture. Her work has been recognized through numerous awards, including the 2024 Journalist of the Year Award from the San Diego Pro Chapter of the Society of Professional Journalists. Her reporting on treatment options for San Diegans struggling with addiction and her coverage of San Diego's housing and homelessness crisis has been widely praised. In addition, her years of dedication and compassionate, in-depth reporting have made her an authority on the homelessness crisis and has kept public officials and San Diegans, housed and unhoused, better informed. Her work has been recognized as being instrumental in forcing the city of San Diego to confront the homelessness crisis in 2017. So, Lisa, are you there to join us?
Yes, I am. I am getting my slides ready. Thank you for the very kind introduction.
Thank you, Lisa. Again, really, really appreciate you taking time. And I just want to just tell you that I was really impressed with Lisa because this is actually her birthday, right, Lisa, or something?
It's my birthday weekend, my 40th birthday weekend. So
Yes.
I apologize that I can't be with you all. If it were a different weekend, I'd be there in person, but I definitely was very passionate about still participating. So thank you so much. I'll get started here. So first off, I just want to say you all are hearing from a great group of folks today. Kevin, Brett, and Jim are all considered to be at the top of their fields in terms of these realms that they're speaking about. So definitely want to give kudos there. So I think I'll start just with kind of briefly explaining how I got into this. We mentioned that obviously I've been a reporter writing about homelessness for many years. It's actually been about 10 years now, which is a long time for a reporter to be on one topic. And I would often see these scenes like you see in this picture here. This is a rather dramatic one, but a person on the street who's clearly homeless, who clearly is in need of some sort of medical care, or maybe actually has that hospital wristband still on. And it's very apparent that they were just in the hospital and we're left to wonder what's happening there. And so a colleague and I decided to, and hopefully my slides are showing up okay here. I think I have to switch them up here. So we decided to embark on a project, Peggy Petey and I, who's a wonderful photographer, starting with the question of why are so many homeless hospital patients quickly landing back on the street and not getting the care that they need? So as a reporter, I always want to start with data to understand what's going on. And in doing so, and this data is newer data than I was able to present in the series of stories I did that I'm talking about today, but we can see that there are many homeless patients that are pouring into hospitals. And what's happening is, as the population grows, there are more homeless patients also ending up in hospitals. So in San Diego County in 2023, more than 12,000 individuals were discharged from local ERs. And you can see the average number of visits per person was about 3. What that means, as many of you in the audience know, is that there are many people that are coming in a lot more than 3 times. And those are often the people that we're seeing on the street, as I did starting this project. So what's happening with that? So more people, as I said, are falling into homelessness across the country. And what we're finding too is that there are more seniors that are becoming homeless, and that it's often taking longer for people to move off the street. And the longer someone is on the street, the more likely they are to develop chronic health conditions. And homelessness just really exacerbates any kind of health issue that someone has. And I know earlier Jim was mentioning some of the research on just the higher, illness and mortality rates in the population, which I mentioned in the slide. And we also just are seeing in the last few years, in particular, a rising death rate among the homeless population. So a 2024 study found really dramatic increases in overdose deaths tied to the fentanyl epidemic, but also tied to chronic conditions like heart disease, diabetes, and then just conditions of life outdoors that, you're more likely if you're homeless to end up being hit by a vehicle, for example, or being exposed to heat or cold. And while obviously in St. Louis, I know I've been to St. Louis, actually some family in St. Louis, so I know it gets quite cold during the winter. You might expect that more people would be dealing with the cold. The thing is that across the country, we're seeing people, including in San Diego, which I know many of you are probably like thinking, oh, San Diego probably has lovely weather all the time. It does, but it still gets pretty cold and sometimes pretty hot too, and that affects these patients. So what are some of the top reasons folks are ending up in the emergency department? I'm not going to go through all of these in great detail here, but I think, what I would highlight is it's a lot of, different skin infections, pain tied to just the realities of being on the street, abdominal pain, superficial injuries, some mental health. A lot of these things don't sound super serious, and we'll talk more about that as we continue on here. So the next slide is telling us where are these patients ending up after they leave the hospital. And I remember the first time I saw this data set, that discharge to home just never sat well with me, because we know that many of these patients do not have a home. 93% of the patients in 2023 were discharged to home or self-care. Now, some of those may have ended up in recuperative care. We don't know, or maybe they did have a shelter. But the bottom line is, this is just really unsettling data if you know much about this population, because you understand that people are going back into the conditions that they were in before they came into the hospital that may have been exacerbating their health challenges. So how did I get this data? Because I know folks may be wondering, because this isn't necessarily data that's available all over the country. So in California in 2019, a law took effect that required hospitals to establish plans for their homeless patients to try to link them to shelter or other options. That was SB 1152. Now, when I was digging into this, what I found is that this law really increased the tracking of if homeless patients are being given items such as food or weather appropriate clothing, or just the fact that there are homeless patients and really quantifying that. But it did not result in new resources. It did not fund new shelter beds for this population or other post-discharge options, which is a problem. So I'll kind of go through some stuff quickly just for the purposes of conversation that I'm sure all of you in the audience already know. The healthcare system is extremely burdened. There's a lot of pressure to move patients out of the emergency room or out of inpatient beds to make space for others. Most homeless patients have Medicaid insurance, at least for now, and the reimbursement rates are often well below those of private insurers. And step-down care options are really minimal, especially for people that have Medicaid insurance. So Now I would like to start introducing you to some of the people that I met and some of the key problems that I identified. One of the first very obvious ones to me was that there are not set aside shelter options for homeless patients. So that means essentially that homeless patients, after they are discharged from the hospital, may be given a sheet of paper that tells them where they might check in to try to get shelter, but they're essentially getting in line with everyone else. And that often means that they don't get shelter. So a couple examples. This is Joanne, and I had met her outside of what used to be San Diego's Homelessness Response Center in downtown San Diego. And she had been treated for the flu. And she said after she was discharged from the hospital, she was directed to come to this resource center and essentially get in line with everyone else that was waiting for shelter. And I think on that particular day, I want to say it was about 16 or 17 people that were waiting in line. And she ended up, the first time that she showed up, there wasn't a bed available. So she ended up going back down to Chula Vista, near the hospital where she'd actually been treated. Chula Vista by trolley and bus, which Joanne was taking to get to the center, was about 40 minutes away. So this was one of the additional times, not the first time that she'd shown up, but one of the additional times that Joanne showed up. She got herself up early in the morning because the check-in time at the center that it opens at or had opened at 8 a.m. It's closed now, but would open at 8 a.m. and you wanted to be one of the first people in line. So she started her day early on the day you see her pictured here, and took the roughly 40-minute trek from her encampment in Chula Vista, south of San Diego City, to stand in line, and she did not get a bed on this particular day. And there was another patient, Michael. I believe I had met him maybe a couple days before I met Joanne, who's pictured here. He told me that he had repeatedly shown up in line to get into a shelter at this particular center. And I will never forget, he was sitting on a bench outside of this check-in center hoping to get a resource. And he said, I'm going nowhere fast. I caught pneumonia. And that was after he had been previously hospitalized. He still had his band on. He showed me, allowed me to take some notes on what had happened to him. And I was meeting him after one of the latest discharges from the hospital, where he now had pneumonia after checking in multiple times. Another key problem that I identified is that there's insufficient discharge planning and training about homeless patients. I was listening into Brett's presentation just before mine. I think it's really important, and I know Jim touched on this as well, just how hard it often is for medical staff to really empathize with the conditions that these individuals are going back into. Meanwhile, they're also dealing with, and I'm empathetic to this as well, this pressure to get people moved on out of the hospital to make room for others who desperately need beds. But there's often just a lack of awareness or availability or coordination related to step down options. So sometimes the combination of those two things can mean that people are discharged before there's a place identified for them to go. I remember one of the conversations I had on this topic was with a former UC San Diego medical social worker who really had certainly some moral injury tied to discharges that he often tried to prevent. And he said to me, the constant theme is they're medically cleared, get them out. And he would often look at these patients that, he was told that they were medically cleared, and he would recognize that if we discharge them right now they're going to be back in the hospital within a couple days, or they don't have the equipment that will work out in the field. They don't have a home to go to manage something like a catheter, for example, successfully, and they're just going to come right back. And I know many of you in the audience know that when patients repeatedly return, that can have negative financial implications for hospitals in more ways than one. Another key problem that I found, and this one surprised me in light of some reforms that had been playing out in the state of California, was that there have been challenges quickly connecting patients to post-hospital care. Now, at a high level, I understood that. But at the time I wrote this story or series of stories in early 2024, and still California is in the midst of Medicaid reform known as CalAIM to try to make it easier to connect high-risk patients who tend to cycle in and out, which includes homeless patients, certainly, to resources that can help to lessen that cycling that often happens. And one of the features of the reform was that Medicaid plans would provide what's known as community supports. And one of those community supports is recuperative care. Recuperative care, for those who may not be familiar, is basically a place where homeless patients can recover after a hospitalization, maybe a surgery, or even just if they've, had some sort of medical issue on the street, sometimes they can qualify to come from the street. And really I would say when the community supports tied to this Medicaid reform were announced in the state of California, advocates were so excited because they thought this will make it easier to fund recuperative care beds and also make it easier to get patients into them, since now there would be community supports in folks' Medicaid plans that maybe could more easily, the Medicaid plan could help to connect them to this service. And what I found initially looking at this was actually that there were huge bureaucratic hiccups with this rollout, and often a lot of confusion, even among very well-meaning social workers and other people that wanted to get folks into care, were really struggling to make that connection. It's my understanding that this has improved since I last checked in and pulled all of the data. But it was really sad to see, because I just time and again was meeting patients that really would have benefited from this service. Really quickly, I do want to introduce Jerry, who's in this photo here. Jerry was grateful to actually be in a recuperative care. And I think this photo is illustrative because you can see he has his CPAP machine on, which would certainly be really difficult for him to have on the street. But he was in a recuperative care program where he could safely put that CPAP machine on overnight. And he also had a bathroom that he shared with another homeless veteran. And so, many of us as we get older, we need to have easier access to a restroom, and Jerry was grateful to have that. So now I'm going to start introducing you in detail to more patients. This is Cece. So before I met Cece, who was 60 years old at the time I was doing this reporting, she had stayed in an independent living facility, and she had diabetes, and had been open about the fact that sometimes she had struggled with that. But by the time we met in October 2023, she was on the street. And she was in and out of the hospital with blood sugar issues that she was really struggling to manage outdoors. For example, she told me she was supposed to keep her insulin bags refrigerated. That certainly couldn't happen on the street. On the night we met, actually initially over the phone, because an advocate had found her and she happened to have her phone charged. Thankfully, we talked on the phone. She had gone to the hospital for blood sugar and blood pressure issues. And she was sleeping outside of that center that I mentioned before, the homelessness response center, where people check in. So after each day, she would go and basically sleep right outside the center so she could be one of the first few people in line. She was still waiting in line around Halloween when she fell and said she couldn't get up. And she was kind enough to help me get her hospital records so I could look into, what was happening while she was being treated. And hospital notes at this time, they were suggesting that she might have sleep apnea or be intoxicated somehow. And that didn't seem to add up based on my conversations with her. So I found that to be really interesting, that there seemed to be a thought that she was using some sort of substance. Um, and she, during this time, she continued to actually stay in the hospital um, from Halloween and through or into early November. And I happened to have a conference up in Oakland. And so I was keeping in touch with her over text message. And she shared with me one day in early November that she had had a discharge conversation. She was going to be discharged the next day, she thought, but she was feeling pretty upbeat about it. She seemed to think maybe there would be a place that she could go. But then she was discharged. And I will never forget sitting in a conference room. Someone was presenting. Actually, Brett was at this conference too. And she texted me that she had been released. And it was very clear to me that she was extremely disoriented. She told me that she had fallen to the ground on her way to try to get to a bus stop because her knees hurt. She was very tired. She was finally, with time and just continuing to just try to persevere, she did get to a bus stop. But then she got on the bus and she didn't know where that bus was going. She didn't know what number the bus was. So I actually remotely from Oakland, she on the ground in San Diego, I was pulling up information about the bus route to help her understand where she was and help her navigate. Um, she ended up back on the street downtown, waiting for a bed, which she did ultimately end up getting one, which we'll talk about in a moment. But she ended up in the hospital again multiple times in the days that followed. She was describing she had now incontinence issues that were popping up. She said it was hurting to use the bathroom. By November 10th, her stomach was hurting quite a bit. And she, meanwhile, through all of this time, was trying to get a shelter bed. She finally got one on November 11th, which helped to stabilize her a bit. And I think this is a really important end note here. It turned out that she had a bladder infection. Many of us know when folks have an untreated bladder infection, it can make them disoriented. It can make it harder for them to process things. It can make them perhaps appear intoxicated. She had a fairly simple health issue on top of obviously, her diabetes and other challenges. But because she repeatedly kept getting discharged to the street, it was harder for her to comply with medication, to really care for herself, to keep clean. And that really exacerbated what she was dealing with. So next, I want to introduce you to George. So George, at the time that I met him, was 65 years old. He first landed in an ER in February 2023. He came in overnight on February 1st, complaining that he was having some pain when he was urinating. He ended up getting a Foley catheter, which he was really anxious about. By 1:45 that day, he was back in the hospital because he had actually fainted in his tent. And he ended up being treated and discharged with the Foley catheter still intact. On February 3rd, he was brought to an ER in an ambulance because there was blood in his urine with clots and he was having a lot more pain. And he ended up getting diagnosed with acute cystis, and he was given pills and a new catheter, back in the hospital a few days later after that. And really every few days for a while with lots of discomfort. He described to me how embarrassed he was to have the catheter on the street. He was constantly worried when he was sleeping on the sidewalk, was he going to roll over and was it going to burst because the catheter had blood in it? He just pleaded multiple times, could he be held at the hospital because he was having so much pain and struggle with the catheter, and was basically told that he wasn't going to be able to get medications or other treatments that were more significant until he could get in with a urologist, and there just wasn't a quick turn appointment available. He says that he was never offered shelter or recuperative care. He said that he felt hospital staff treated him as a nuisance. And at one point, George was diagnosed with a UTI, an inflamed prostate. He was really very, very concerned at this point. His father died of prostate cancer, and he was really panicking that he was going to suffer the same fate. And no one at the hospital was really explaining, despite his repeat visits and likely running into some of the same staff, nobody ever really sat down with him, he says, and explained what's actually happening to him. By March 11th, hospital records that he allowed me to review showed that he showed up at UCSD in the ER with leakage from the catheter. And he actually told hospital staff that he was considering trying to overdose on fentanyl because he smelled like urine. And now he actually was in a shelter, but he was just extremely embarrassed to be having to clean this catheter at the shelter. And because of the number of people in this men's shelter, there was limited time that any one person could have in the bathroom. So it was just really unwieldy for him to try to care for this. So he was just extremely embarrassed. Sadly, after he was vulnerable enough to make that admission, he was released from the ER just 10 hours after he arrived. And the hospital notes said that they planned to give him 14 days of medication, clothes, snack, and a bus pass. And George just continued to be just extremely demoralized. Thankfully, he didn't try to overdose himself, because several days later, when he was really down, some friends were encouraging him to maybe go to that homelessness response center that I mentioned and try to see if he could find an advocate there. And so he did. And when he showed up at the center, he happened to meet Janice, who's with an organization, Housing for the Homeless. And she saw that catheter and she saw how disoriented he seemed. And she said, I'd like to call for an ambulance. I think you need to go get some care. And so she ended up getting in the ambulance with him. They went to the hospital, and she advocated for him. And that ended up being a total game changer for George. He ended up getting more tests. It turned out that he was actually resistant to the antibiotic that he'd been given. So, it was acknowledged that the infection that he had was just worsening. And also Janice was able to advocate for him to see a physical therapist and a case manager, and he was able to get into a skilled nursing facility. That skilled nursing facility ended up being also a game changer for George, because there he was able to take his medications, keep his catheter clean, and really recover in a safe and stable place where he could be consistent. And I'm happy to say that George eventually moved into housing. He will, profess that Janice is his angel, and that would not have happened without Janice. Next, I would like to introduce you to Edward. Edward, I do not have a picture of Edward's face because he didn't feel comfortable sharing all of his information, but he was kind enough to speak with me early one December morning when he was sleeping next to a utility box outside of Scripps Mercy Hospital. And he had just, I spoke with him, he's shivering and somebody had given him, thankfully, a blanket, and there was literally his walker laying next to him. It was quite a scene. And on this utility box, there was a purple plastic hospital bag that folks get and may be familiar to folks in your community too. This bag that when you see it, it's very clear that this was a bag they were given at the hospital. He also had a bus pass, and his hospital discharge paperwork was just all sitting on this utility box. And George told me he'd been discharged the previous night, and that they had actually taken him using a wheelchair to this spot and then deposited him essentially in the grassy area and laid his walker next to him. And so I asked Edward, can I look at your paperwork? And he agreed to let me look at his paperwork. And it showed me that, he was released to his previous dwelling location, which is discharged to home, as we talked about earlier, and that he had gotten, some paperwork about shelters, but he had been discharged about 9:30 at night after all of the shelter intakes were done for the day. So there was no way that he was going to be getting into shelter. And as I continued to page through this paperwork, I saw that he had been treated for generalized weakness. He's HIV positive and had been diagnosed with malnutrition. And he told me that he ended up in the hospital the prior night because a neighbor had found him literally not moving for a full day and had been concerned. He was staying actually in my neighborhood on a sidewalk. And a neighbor asked if they could call 911 to get some care for Edward, because it just seemed that he didn't look well and he was not moving. And so Edward agreed. As I continued to talk to Edward, he shared with me that he had previously stayed in a recuperative care program and that he wanted to go back. The problem was that apparently his insurance company was denying his return to that program for unknown reasons. And he said the hospital had tried to advocate for him to go back, but the insurance company was not allowing it. Now, at the time, Medicaid policies in the state of California allowed for recuperative care stays of up to 90 days, and they did not prevent patients from returning to facilities if they were hospitalized again. And yet George had been caught in this bureaucratic situation where the insurance company had the ability to determine whether he was going to end up back on the street or in this recuperative care. And obviously he was continuing to need treatment and landing back in the hospital repeatedly. This photo that you see of Edward was actually, I believe, taken a few weeks before I met him. Peggy Petey, the photographer that I worked with, had gone out with a group of nurses that provide treatment to folks around the hospital and just support to folks around the hospital who look like they have medical issues, because there are so many people that are being seen still with their, wristbands, hospital booties, and other things still intact, and the person doesn't look to be healthy. And so they interacted with Edward. And I found that really interesting because I wondered, was that, so I didn't get a chance to talk to Edward at this time. I wasn't out with Peggy that night, but, just prior to this photo, had Edward been in recuperative care, or where was he in that journey at the time? But he very much wanted to be in that recuperative care program. The last case study that I have for you is Ashley. This is a very sad story. So Ashley is unfortunately no longer with us. Ashley was 25 years old, and for a long time she struggled with bipolar disorder and addiction. And her parents, around the time that she did land in the county psychiatric hospital, had actually been praying that she would end up there because they were hoping that she would end up on a longer term hold. And they were told that this particular hospital was most likely to effectuate something like that. At the time, she was just really spiraling. For example, her mom was receiving multiple calls from people that were meeting their daughter, who did not know her, um, and were trying to help her connect with her family as she was experiencing hallucinations and paranoia. She, at this time, she'd abandoned the apartment that she had downtown. She had taken impulsive trips to Mexico and Orange County, and she'd lost touch with the treatment program that she had been enrolled in for a long time. And then in February 2021, unbeknownst to her family, she did land in the county psych hospital, um, after a police officer watched her run into the middle of the street, without shoes on. And that officer deemed Ashley to be a danger to herself and gravely disabled after watching two vehicles nearly hit her. Doctors put her on an up to 72-hour hold after she got to the hospital, and continued to monitor her. But she was discharged early the following morning after medical staff at the hospital decided that the behavior that she had been exhibiting that led her to run into the street was related to methamphetamine use, though they did not test her for drugs. Um, Before the discharge, an on-call therapist with the treatment program that Ashley had been enrolled in um, spoke with a doctor, and he took some notes on this that Ashley's family shared with me. He had requested in this conversation, this pre-discharge conversation, that they wait until Monday to discharge Ashley so that her treatment program could help her with that discharge. This was a Sunday call, happened over a holiday weekend. She ended up being discharged the next day. And unfortunately and tragically, 10 days later, Ashley ran into traffic on a freeway and she was killed instantly. Her story really speaks to challenges for people with co-occurring or substance use disorders. Um, Hospitals often will discharge people after they determine that they're no longer under the influence, even when there can be other health issues. And medical folks that I've spoken to about this just, describe this being a really challenging situation because of various civil liberties concerns, but also balancing that, there may be a need for additional testing or monitoring, and sometimes it can be hard to make the case for that. But situations like Ashley's paved the way for some reforms in the state of California. We now have expanded conservatorships to also cover people with serious substance use disorder. But unfortunately, Ashley's situation didn't play out before that. I know, conservatorships are a really controversial topic. And it's not certainly not something that makes sense for everyone. I'm not going to say either way if I think, Ashley should have been conserved, but I can say her family certainly believes that it could have saved her life. Next, I am going to talk about briefly what these case studies have in common. I think what sticks out the most to me is that these folks were mostly navigating their hospital stays on their own, and they were unable to effectively advocate for themselves. Also, the discharge decisions did not fully account for the experiences that they were having on the street.
Can you hear me now? Yeah, can you hear me? Okay, I can. Hey, real quick.
Um, okay. And also, all of these patients could have qualified for some sort of additional care, but that doesn't mean that they got it. And also doesn't mean that it even would have been available if they tried to, if the medical professionals were trying to provide it. But they all would have qualified, and been good candidates for other step down options. So how can street medicine help? Street medicine and street level care can absolutely help a lot of these patients avoid hospital visits, and honestly, at the lion's share of cases, could have helped
The
to
long,
de-escalate their health situations. Many of the folks that I met doing this reporting started out with pretty minor health conditions that could have been treated on the street, or perhaps even some sort of connection from street medicine to a higher level of care if needed. Also, Brett, I don't think talked about this as much during his presentation, but one thing that street medicine programs are starting to do more of, including Brett's program, is actually assess and advocate for homeless hospital patients. So if they have someone that lands in the hospital that they're already working with, or someone that maybe is newer to street medicine, hasn't been enrolled in the program before, a hospital will connect that person with street medicine, whether it's a team that they have or haven't interacted with before. And then street medicine can actually evaluate, okay, here are the needs that this person would have upon discharge. Is it really realistic to expect that this person who has to climb over a fence to get to their encampment is going to be able to use successfully using crutches? Well, no, maybe that's another reason to try to get them into recuperative care. And also that provides just really important advocacy that a lot of these patients desperately need. And also street medicine can help coordinate with both medical and homeless service systems to make sure that there's actually a bed when someone is being discharged from the hospital, and also that they have the support, and maybe, a ride to an appointment that they may need to go to as a follow-up. Those can be really, really crucial. So with that, I am going to put up my last slide with my organization, Voice of San Diego, and my contacts if anyone has any questions. But I think we have time for a few questions too. I will defer to the organizers on how much time we have, since I know we're a little behind.
Any questions for Lisa?
Hey, Lisa, it's Kevin.
Hey, Kevin.
Fagan. Yeah, we know each other. Lisa contacted me a few years ago. She organized homeless reporters around the state to try to get coordinated and cover this issue better. And I just thought she was so talented and so eager and so driven that she's been a wonderful addition to the whole reporting landscape on homelessness. So kudos to you.
Oh, thank you, Kevin. That's very kind of you, because I will say Kevin was, we say he was one of the OGs of homelessness reporting, and many of us look up to him.
Thank you, Lisa. It was excellent. And it was great to see from your angle and your perspective, the people that we care about. Do you have any kind of advice for folks practicing street medicine to form alliances that will advocate better for the things that people are experiencing with reporters, with folks in your arena?
Yes. So I highly recommend finding out who are the reporters in your community that are doing a lot of stories about homelessness, whether they are broadcast news reporters or print reporters, and invite them to come out with you. Invite them to see the work that you're doing, or to just let them know about events that you're holding. Or even just say to that journalist, hey, would you be up to get coffee? I'd really like to talk about what I'm seeing with these patients that I'm serving. And I think you'll find a lot of us are really interested in learning more about this angle. And many of us, we want folks that can connect us to people on the street, that help us tell important stories. And healthcare is a big part of the homelessness story, a huge part of the homelessness story. And I would say an increasing part of the story as we have an aging population on the street and more people that are taking longer to get housed. Thank you for the question. That's a great question.
Hello, Lisa. Thank you so much. This was really amazing, the stories that you've collected over the years. Again, I'm a neurologist here at Mercy Hospital and do not have lots of experience and haven't been actually reading or listening or learning about homeless or unhoused. So this is really an eye-opener for me. But I have a question. This is great work, lots of work from you journalists to get to the stories and to put it all together, and year after year, like you said, decades of hard work. So how do you connect that with policymakers, with the people who actually are decision makers who can make a difference at a sort of a more societal level, as shall we say? I mean, it's wonderful to report stories, but it is really important that somebody reads your stories, and those who have a power and decision makers actually use those stories to make the right decision.
I absolutely agree, and that's an excellent point. And I apologize. There's a little bit of work happening behind me. I'll answer the question. If we have another one, I'll run over and close the window. To me, it is absolutely the reason that I do this work is because I want to make a positive impact. Just like all of you, I do what I do because I want to help others. And a lot of my reporting has had a positive impact. So I think kind of going back to that previous question, talking to reporters about problems can help to really elevate situations that you're seeing and drive positive change. On this topic, I will say it was frustrating to me because there was such a complex web of problems. We identified, obviously, in the reporting, significant challenges. I think where there have been improvements, it hasn't been as much as I would like to see. And I think it's because it requires multiple different entities to come together around a solution. And one thing that has improved is now there are more regulations around Medicaid plans and recuperative care. And so there is more seamless movement. I know I was also invited to moderate a panel that a lawmaker in the state of California put on about Medicaid reforms in the state of California and evaluating them. And I was really cheered by the fact she told me to completely be myself. And so that crowd heard multiple stories of the folks that you heard about today in the questions of state officials and a county official. And the county official ended up saying that he actually thought that basically he acknowledged he was now advocating for folks to be automatically intaked into recuperative care, just the assumption that they will qualify. And I know the state was moving in that direction and appears to be moving more in that direction. But I think these stories do really matter, and the humanity of the people in them matters. And so any of you that are working with reporters, I would just advise, don't be so protective of the individuals. Sometimes people are really protective. I know Kevin could probably tell this story from many times in his career too. But when people get to know these patients, they can see people they know in them. Like I know many people could probably see someone they know in George. We all know someone who's struggled with prostate issues. But now imagine, put on top of that, you're homeless on the street. I think everybody can understand how hard it would be to manage a catheter on the street. So the humanity and even just the little details about those patients actually helps to drive change for people to really understand, okay, yeah, it makes sense. Actually, it would be cheaper for somebody like George to be able to get into recuperative care or a skilled nursing facility than to have him just keep returning to the hospital and also just suffering extreme, trauma on his end, fear about, the fact that he was worried he literally might pass away from this issue he was dealing with. So thank you so much for the question.
Hi, my name's Sarah. I am a street outreach worker. I'm not a fan of microphones or rooms full of people, but hello. I the work that you all are doing, that your presentation really like speaks to the need for advocates for the individuals that we serve in the systems that are built to serve them. I see a room full of people that represent a lot of resources and potentially, the right ears to hear this message. And that is that I dream of a world where the systems don't require advocates to get the services that people, the services exist and the people are asking for the help that they need. And literally, they're more likely to get the help that they need with me just being in the room than they're, just them telling you what they need, So, ooh, one document to end all documents. It's like we just the layers and layers of complexity that we impose upon people is such an oppressive part of the systems of helping. And all these stories illustrate that. We see it day in and day out. I do street outreach. I just recently started working under the Beacon Grant, which was created by Mercy to serve the highest utilizers of the ER system. Some of the individuals that we serve, if you do the due diligence and get in there and like really look at their stories, which we have points of data and documentation out the wazoo, we just you can see their story through those documents, but they will tell you also their story, and that is one of just repeated attempts and fails due to policies and procedures that are not built for the people we serve. So, wonderful, wise people. I struggle. I want to know, what is the shortest distance between the people we serve and the things that they need, and how do we get more of that to the people? Street medicine is a great way to do that. We need more street medicine folks. We need more street outreach people, but we need more access for people that actually just do get themselves to clinics and hospitals. And I'm not sure there's a question in here. But I don't want to think about the complexity. I don't want to think about funding streams. I don't want to be that advocate. I just want to be able to serve in the ways that I can serve as an individual with limited time and resources. So, who in this room wants to help make more of these things happen?
Well, thank you. Thank you for wonderful comments. I think we all feel your frustration. I think that's why we're here, because we want to make this world better. And I think probably the best place to start is just to keep doing what we're doing in terms of advocacy. Lisa, do you have any parting suggestions and advice and wise words for us before you leave?
I would just say that, I do agree with everything that was just said objectively based on my reporting, that often folks are showing up and being turned away. And I also want to echo, the first time I heard Brett talk and talk about the radical love that comes with street medicine, it took me a minute to kind of, really fully process that. But what I find in my reporting too is so often, and I know you all are experiencing this too, you go out into the field, you talk to somebody, you have a conversation, and the person will say, "You're the only person that talked to me today," or "You're the only person that cares about this." And I think the more that we can all just go out and show that love and care, through whatever our work may be. If we're a hospital social worker, we're in street medicine, wherever it may be, I do think it goes a long way. For many of us, it may know, even for me as somebody who writes about things on a more macro level, I may never have the impact that I would truly love to have, but I think every little bit helps. And for every person that you interact with, it matters. So I guess that's what I would leave you all with. And thank you so much for having me and all the great questions and comments.
Thank you, Lisa, and happy birthday again.
Thank you.
Thank you.
Thank you all.